Welcome to Think Big for Africa podcast. On this podcast, we will bring you interesting conversations with local, national, and international African leaders from all walks of life, home and abroad. Leaders who are doing their bits to progress Africa's development. Conversation topics will range from education, science, health, leadership, politics, business, and many other global issues. Conversations about everything that concerns Africa's development. Africa has so many wonderful achievers worldwide, and this is exactly what we will bring to you on Think Big for Africa podcast. Stay tuned.
Hello, welcome to the Think Big for Africa podcast. My name is Ekene Banye, your host. Today, I have another beautiful young lady. She is a consultant breast surgical oncologist and a professor in surgery at the University of Aga Khan University Medical College in Nairobi, Kenya. Her name is Miriam Mutebi. Miriam, how are you?
I'm very well, Ekene. How are you today?
I'm very good. Thank you for being patient. Thank God you called me while I was on the motorway, driving very fast. Yeah. So, Miriam, I know there was a reason why I wanted you to be on this podcast today. And I want you to tell my audience a little bit about you and your work, and they will soon realize the reason. So, tell me, did you hear me?
Yes, I just heard the beginning. We went off a little.
Oh, okay.
You pretty much, at least what I got was you wanted me to share a little about my work.
Yes, about yourself first, and then about your work. Yes, because I like my guests to know something about something a little bit personal about you. Yeah. Mm-hmm.
Right. Okay. Well, I like to say I'm in the hope business, which I always say I'm a breast cancer surgeon by day, and then a clinical epidemiologist and health systems researcher by night.
Okay.
Just to clarify, I'm an assistant professor, not yet a full professor.
Okay.
hoping to get there eventually. But my research focus has been on understanding barriers to access for women who have cancers in our region, and trying to design interventions that talk to those barriers. In terms of something a little personal about me, I would say I like to cook, but can't be bothered to spend 21 million hours trying to prepare something. And so I'm currently running a random Instagram page called the Indolent Cook, where the trick is healthy meals, but prepared in under half an hour. It's actually very interesting. My initial sort of name for the page was going to be The Lazy Cook. And Instagram was already like, no, you can't do Lazy Cook 600. So I was like, how many Lazy Cooks are there out there? So yeah, back to the Indolent Cook.
Okay.
Yes.
So you are a surgeon. So let me break it down the way I understand it. And I think it will also help my audience to understand this. You are a surgeon. You are a doctor and a surgeon, okay? And drilling down, you are an oncology surgeon, right?
Correct.
And again, drilling down, you are focused on breast oncology. Okay.
Correct.
So, okay. So, one,
very
you're
good,
a
very
doctor.
Good so far.
Yeah, you are a doctor. You are a surgeon. You are focused on oncology, and you are focused on oncology in the breast.
Correct.
Very good. Very good. I get it. Okay. So now,
so this shows that just pretty much reflects on how much time we've spent in school. Hey.
Exactly. So this is what I want to know, and I think some members of my audience will want to know, how did it get here? It's important,
right?
Yeah.
I think I just always joke, because there was a time that when people would write, sometimes when you have to go and fill out forms and they ask your occupation, and I always had to write student, because it feels like you're pretty much in school for most of your life. But the path to surgical oncology is, well, first you need to have your degree in medicine, and for us, we usually do it as an undergrad program. So you do your 5 to 6 years of general medicine, and then you do a degree in general surgery, because that's the background, which depending on the program takes anywhere between 5 to 6 years. And then you do a subsequent fellowship in surgical oncology or breast surgical oncology, which takes about 2 years. And so, that's why sometimes you just feel like occupation student. But the good thing is, I mean, as a clinician anyway, it's not necessarily, I mean, you are a permanent student, because again, it's self-directed, but pretty much lifelong learning, because what tends to happen is medicine, and especially oncology, is so dynamic in terms of new advances, new techniques. So you absolutely need to you need to stay on top of your game. You need to be, reading consistently and constantly to see what's new, what is the latest evidence, so that you're always giving best practice for your patients.
Yeah. Good. Now, again, some of my audience may not really understand when we use the word oncology. Okay. So use the layman language to describe what you do. Actually, the layman language everybody knows.
Well, keeping it simple, I would just say what I said earlier: a breast cancer surgeon.
Exactly.
Meaning we do surgery for breast cancer.
Yes.
That's a simple way of looking at it.
Good. Thank you for that. So I've read online that you are the first female oncology surgeon, breast oncology surgeon in Kenya. Is that correct?
That is correct, but thankfully not the last.
Yeah, of course not. Of course not.
I'm happy to report there's a few more in training, and one who's just completed the training. So
excellent.
Hopefully in the next couple of years, there's going to be a whole lot more.
Excellent,
for sure.
Excellent. So being the first at anything is challenging. Okay. So you are in a unique place that 99.9% of people are not in every profession, because there's only one first, okay, for anything. Okay. So how does it feel to be the first female breast cancer surgeon in Kenya?
I think that's an interesting question. I think for the most part, it's a responsibility, because again, you do want to. I mean, it's not just about being first. It's about how do you expand the services? How do you create an impact? How do you make sure that you don't necessarily want you don't want your accolade to be the first, right?
Yeah.
You certainly want it to be looking at in terms of impact. What have you been able to do? And what have you been in terms of, influencing healthcare, influencing strategy? And because it's also, as you said, a responsibility, because then, and sometimes it's an internal pressure you put on yourself, but you have the responsibility to show other, clinicians, both male and female, that, you can do this, and you can have, an impact to your community, and also ensure that if there's any other people who are interested or engaged, and you sort of show them the way to get there. And so there's definitely a role, I would feel, additional pressure you put on yourself to say you need to be a good role model, because then you are sort of setting the bar, as it were, for everyone coming after you. And so unfortunately, as you said, the novelty is this is the only interaction somebody's had. So you'd better make sure it's absolutely excellent. Exactly. So that,
So I also read that since December 2020, you were appointed to the board of directors of the Union for International Cancer Control, UICC. Tell me, tell me about that, about the UICC and your role as a member of the board of directors.
Yes, so the UICC, as you said, is the Union for International Cancer Control. And it's one of the global bodies that tries to address cancer control in several countries. And so they have about 1,500 member organizations, about 1,200, representing about 172 countries that represent pretty much the world's major cancer societies, ministries of health, patient groups, and also includes a couple of influential policymakers, researchers, and experts, all who are geared towards helping to improve care along the entire cancer care continuum, whether it's all the way from prevention, treatments, control, palliative care, so covering the whole spectrum. And I think the UICC is unique in a way that it's able to bring the global community together and put it towards specific action points, key around advocacy, training and fellowships, where you try to have knowledge exchange, where different clinicians from different parts of the world can go and access short courses or even longer fellowship trainings and return to their home environment. And this is not just, say, for doctors, it's for the entire spectrum: palliative care, clinicians, oncology nurses. So they do try to work around capacity, but it's also about knowledge sharing. And so we have had to sort of shift the model to virtual. And so there've been quite a number of regional sort of dialogues where people get to interact, exchange ideas around cancer control, what's working for you, what have we had to rethink as a result of the pandemic, how could we better deliver care? And so that's definitely, I would say, provided a platform for that knowledge exchange. And then, of course, from a policy level, we do have the World Cancer Leaders meeting. That's actually coming up in Boston later this year in October. But that's pretty much bringing anyone who's so to speak, or influential in terms of cancer care globally. And that is trying to direct the narrative or trajectory of where we feel that cancer care should be heading and what the leaders should be prioritizing for their patients in their respective environments. So I mean, it is humbling, and again, quite a responsibility in order to think of you're going along all these different aspects of care, whether it's from the policy level, whether it's from the treatment level, whether it's from the advocacy. again, advocacy, I feel, is something that we definitely need to develop a lot more of. And sorry, I'm going to go off on a tangent.
No,
I feel
very
quite
I'm happy
passionate about.
for you to do that. Yeah.
Yeah, I feel that we've definitely had an increase in cancer advocacy.
Yeah.
But I think part of the challenges, and this is part of my research as well, some of the barriers that we have, especially to our cancers getting diagnosed early, is that there's still a lot of stigma around around cancers, and then there's also a lot of fatalism, which means that people hear cancer and think automatically
they're already dead. Yeah.
Exactly. And so if you think you're already dead, then why in heaven's name would you sort of go to get treatment, right? And then there's also, I would say, a bit of, so those are, I would say, and then there's lots of alternative therapies and things. So there's definitely a need for advocacy and I would say strategic advocacy. Now we have, in sub-Saharan Africa, I think we've increased the awareness advocacy, meaning we've gone out and sort of sensitized the community and sort of try to get people in. But I think there's lots of roles around where we can develop our advocacy. For instance, there's lots of, as you said, as a result of stigma, there's lots of discrimination. Yeah. And I have patients who basically from our work, patients tell me, listen, you even at work, people are looking at you like a quote unquote coffin in waiting. So nobody's, you either lose your job or you're not, because they're like, you're taking too many sick offs or whatever, or you can't qualify for promotion because why do I want to promote you and you're going to be, keeling over in like another couple of months, that kind of thing. And so sometimes patients won't even disclose their status to their employer just to avoid some of those challenges. And I'm like, legal advocacy, how do you then protect the rights of patients, right?
Yes.
Again, the other thing is, of course, one of the major barriers to care is around access and the fact that many of our patients in sub-Saharan Africa are having to pay out of pocket, right, for their healthcare, and that frequently results in catastrophic health expenditure. And the end result of that is not only do you get diagnosed with advanced disease, you don't frequently complete your care. Yeah. And I mean, I would say locally, for instance, they've had a national hospital insurance fund that has tried to mitigate some of the costs, but it's still, I mean, it's a great start, and we're definitely seeing more patients completing their cancer treatment journey. But more, I think, needs to be done. I mean, I remember when I was in internship, and these are like truly heartbreaking sort of stories. Like, what would happen, Ekene? You would find, for instance, like if you're going to treat a cancer with chemotherapy. Yeah. How the chemotherapy works is that, the cells take a particular cycle and they regenerate over a period of time. Yeah. And so what happens is that you have to give the chemotherapy at sort of a certain interval. Yeah. Just so that it increases its effectiveness. Yeah. And so what would happen sometimes is you would give your initial first dose of chemotherapy and the patient would just disappear. Right? Wow. And ideally you should be giving them every 3 weeks. Every 3 weeks. Yeah. Exactly. And you're trying to call or whatever and you can't trace the patient, and they come back after 6 months. Yeah. And after 6 months they're coming in and they're so excited. They're like, doc, we've raised enough money for the next cycle. And you're like, oh my God, where do you even start? You're starting again. Exactly. And you're probably starting with more advanced disease. Exactly. The cancer hasn't just been sitting around for the 6 months. It has been growing. Exactly. And so, I mean, part of the National Hospital Insurance Fund has helped to cover some of that, but you'll find that maybe you need 8 cycles and maybe they cover half of that and stuff. So those are things that need to be organized. And then, of course, in many countries, again, they don't necessarily have a national insurance fund. So you're still having to pay out of pocket. And so even the implications of, financial toxicity and who's advocating for this, we're sort of saying globally, we need to start thinking about pushing to universal health coverage. But even with universal health coverage, and you as having a financial background will appreciate that, it's a limited kitty. So how do you, think of creative ways around revenue generation for cancer patients? Do you think about, sustainable small, business enterprises or things that can help tide them through? What is the financial sort of recourse for patients who are having to get their care without necessarily sort of breaking the bank?
See, healthcare, I'll tell you, healthcare for me should be a universal right.
Absolutely. Absolutely.
See, I'll tell you a little bit about me. I was 10 years ago, I was a banker, okay? And I had a stroke, okay? And since then, in fact, 10 years next month, August, okay, I had a stroke. Since then, I haven't been able to go back to normal work, okay? That's the truth. And I would say this, I want my audience to hear, because I know some people who are going to be policymakers are listening to me. I'm able to sit down today, have this conversation without worrying, because my healthcare cost is borne by the National Healthcare Insurance. Okay, in the UK, the NHS. All right, and within the last 24 months to 36 months, I've had a family member go through breast cancer. Okay, and I was able to help her with I took her to all her appointments, took her through the chemotherapy. That's why I know so much about that. Okay, because I've gone through the process. Okay, within the last 24 months. Okay, these healthcare issues are devastating. In the minimum thing is that you can't work, okay, or you can do minimum at work. And when it's combined with the loss of income, it's so devastating.
Okay? Absolutely. And you can imagine, Akene, as you said, I mean, getting a stroke and sort of going through the whole rehabilitative journey must have been quite a challenge. And it's also
yes.
just
as
even
I talk to you, I'm still disabled. So I mean, I'm doing well, but there's so many challenges. Okay.
Absolutely.
Yeah.
And
we need to be able to help our citizens to recover from whatever health challenges they are going through, without demonizing them in terms of you're sick, you're that, you can't walk. So we need to find a way to do all this.
Yeah. And like with the stroke and like with cancers, it's never a one-off. It's a whole journey you're going through. And so getting the support through that entire journey is absolutely critical in order to, just have, improve your quality of life.
Yes.
And give meaning, because otherwise you're already having two hits, as it were. You have the first hit of the diagnosis, and then the second hit of the financial implications, and then the third hit is pretty much what the community is saying about you, or and some of these are part of the social cultural barriers, which is some of the work I do in communities in sub-Saharan Africa. And we actually realize that sometimes I think we don't necessarily talk enough about the social cultural barriers. And sometimes you'll go home and you'll say, honey, I have a cancer, and you're told, honey, there's the door, don't let it hit you on the way out, right? And initially going in, I mean, I sometimes as researchers, you have a few maybe inherent biases or hypotheses and stuff.
Yeah.
And so we did this study in a couple of countries in East Africa and looked at both, public and private institutions as a surrogate for socioeconomic status, just to try and see is it maybe a factor of lack of education or awareness or whatever. And I think this is going to be mind-blowing for you. It didn't matter whether you were in the top of the range.
No, I'm not surprised. I fully understand.
It was still. Literally, I have patients, being told, after surgery, don't come home, figure it out. But you're not welcome anymore.
Yeah.
And so those are some of the issues that we do need to tackle, especially around the community sort of perception of cancers and the invariable and the inherent, I also the attendant stigma that comes with some of those perceptions as well.
Yeah.
I was just saying that, we've talked about the financial aspects and a little about, what the community is doing. But I also say, we also have to acknowledge our own role as healthcare providers in actually being barriers to care. And so we've actually had to shift the narrative around breast cancers because, and other cancers generally, because what we would say about 5-10 years ago is patients in sub-Saharan Africa present late, meaning they, present to the hospital at an advanced stage of disease, but sort of doing an in-depth sort of inner look into, our own role in these. So we've actually moved towards saying delayed diagnosis, because what we've realized is that at least certainly in many parts of sub-Saharan Africa, you'll be interested to know that a patient will on average see at least 3 to 4 health workers before a definitive diagnosis of their cancer is made. And so it just underscores the need to have a well-informed, educated workforce that are able to detect the signs and symptoms and make appropriate timely referrals, all of which has been a considerable challenge in our setting. And so looking at how do we empower health workers? Again, sometimes health workers, patients will come again with advanced disease and they're like, why are you here? Go home and die, right? Which is, again, a disservice to the patient, because irrespective of whichever stage they're at, there is treatment.
Yes.
Now, the goals of treatment may change. For instance, if you're having an early cancer, then you're looking to treat and cure, whereas with a more advanced cancer, you are treating, but with the aim to control.
Yes.
And certainly we have many patients who, having treatments with the metastatic cancers who are stable on medication for years and years on end. But if the health worker as well is telling you, hey, what's happening, like you're a gone case, then that further, reinforces the fatalism of cancer care. And so those are part of the areas that we have been working hard to try and tackle.
Great. Thank you for that. Like I said earlier, you are first on your space. You have opened the gates for many other women to follow your footsteps. Okay. But I know there are opportunities and challenges on that road. So can you tell our sisters who are listening to you and deciding that they want to follow your footsteps, what are those opportunities available, and then what are some of the challenges that they might face on the road?
Okay. Thanks, Akene. I think one of the key pieces of advice that someone once told me is find your passion. Okay. Sometimes people say, I want to do this because my dad thinks I need to do this, or my mom will feel
understand
really,
that
really
clearly.
happy. And in sub-Saharan Africa, for the longest time, you either had to do medicine, law, engineering, or I forget what the fourth one was, but there's kind of like limited options.
Accountants,
I think
engineers,
slowly come exactly.
Yes.
So we've slowly come to the realization, success and what our definitions of those are.
Yes.
But I think the important thing for you to succeed at whatever it is you're doing, you need to be passionate about it and you need to have interest. I always tell young ladies who are coming in to see me, I'm like, you know what, if you're going to be up at 2 a.m., which invariably sometimes in surgery is going to happen a fair amount of time, you had better be doing what you love, because you can imagine you're up and you're, it's and again, the second thing is there's no substitute for hard work. So it doesn't really matter whichever field you're in, whether it's, you're deciding to go into the arts. And I was just saying, my second bit was that there honestly isn't any substitute for hard work. So irrespective of whichever field you're in, you do need to do the time, you do need to put the hours, you do need to dedicate, and there may have to be sacrifices. You may have to think, you know what, I want to pursue my sports. I'm going to, not go out and hang out with my friends. I'm going to go to the, tennis court and, hit a few balls or whatever, or I'm going to spend some time and study a little more on this. But everything in life that's meaningful or impactful does require hard work. And sometimes people sort of think there's going to be a quick fix. As you've clearly seen from the number of years we're in school, there's no quick fix.
There's no quick fix anywhere. See, no matter what people want to do, no matter how, people, especially in this era where we all can see the successful people in all areas of life, but we start seeing them when they have reached a level, and unfortunately we haven't seen any of the work in the background which they have done consistently over time, so we only see them when they are shining, and we say, yes, I want to be like him, I want to be like her. And then when we start doing the work, we get disappointed because we want to achieve the glamour, without doing the work.
Exactly. And I think for anyone who's trying to strive, I mean, it's important to also realize that you are going to make mistakes. There are going to be disappointments. And sort of looking at some of the profiles of, I think that there is the anticipation that I will do this and I will, succeed 100%. Whereas if you look at some of the major, I would say, leaders in our time, they're saying, I've failed, I've tried, maybe 200 times. I failed 97 times.
Exactly.
And maybe I've succeeded 33 times. But it's the 33 that have made a difference. But so nobody's sort of talking about the 99 times where you totally bombed, right? And so looking at how do I, a quick fix or an instant fix for this. So this is, I'm going to go off on a tangent, but it's just something silly that's come through my mind. Somebody was saying, we're living in the world of instant whatever. So
gratification.
Gratification. Yeah. And so there's this silly joke about somebody who goes to this new environment, and he's suddenly bewildered by the supermarket to find all this instant stuff, like instant, mashed potato powder, just add water, orange juice, instant, orange juice powder, just add water and stuff. And then he goes down the aisle and he sees baby powder.
Okay.
And he shakes his head and he says, "What a country."
Oh, well, I hope my audience understand it. Well, like I asked you at the beginning, Now, maybe this question, let's see if it makes sense. I originally thought as a surgeon that you don't go through the same study of normal oncologists, okay? But it seems you did that before you became a surgeon in oncology.
Yes, so just to explain a little, because part of the surgical oncology fellowship is you do initially have to be grounded in the principles of oncology, because what usually happens is anyone who's managing cancer, who's dealing with patients who have cancer, know that it's usually a multidisciplinary team effort. And so you have the surgeon, who's the one who does the surgeries, the medical oncologist, who's the one who usually gives the chemotherapy. You have the radiation oncologist, who's the one who sometimes gives radiotherapy where required. You have the pathologist, who's the one who probably looks at the histology and confirms the diagnosis. You have the radiologist. You have the palliative care clinicians. You have the psychologist to offer counseling and support. So it's pretty much a multidisciplinary team affair. And so part of your initial training as a surgical oncologist is actually getting grounded in those principles.
Those things,
and you do ultimately have to spend time rotating in these different areas. So you'd go to medical oncology, spend a couple of months there, radiation oncology, spend a couple of months, go through to the counseling, psychosocial support. So that by the time you're done with your training, you actually, in addition to the surgery, you have a very clear picture of how the
process. And,
and how this entire mosaic works, always with the patient at the center, but with the entire team around them. And that's important, I think. It's a very different mindset, I would say.
Good. So you'll be able to answer this question. The question I want to ask you is this: the magnitude of frequency of breast cancer in Africa, and then is it increasing or decreasing in the number of frequency? Yeah.
Thanks, Akane. Great question. I would say global. I would say, in general, cancers are on the increase, and breast cancer certainly, because what we know currently is that 1 out of 6 deaths globally is due to cancer. And what should alarm us is that 70% of those deaths are from low and middle income countries. Now, if we're looking at the projections, they're saying we're almost anticipating an almost 70% increase in the number of new patients diagnosed by the year 2040. Now, breast cancer has increased to the extent that for the first time, as of 2020, breast cancer has now become the most commonly diagnosed cancer globally. It used to be lung, but now breast cancer's sort of taken the lead, just underscoring the need. And then, of course, with the greatest projections being in low and middle income countries, should create a sense of urgency for all of us. In terms of the number of cases, again, because in most of sub-Saharan Africa, we don't necessarily have country-based registries. But definitely most registries will have reported an increase in the number of breast cancers and patients diagnosed.
Wow. So
in Kenya, as of last year, we had about almost about 7,000 patients diagnosed. But then again, that's probably underreporting in the absence of a national cancer registry. So the true number is probably is much higher than what is actually reported.
Wow. Like I told you, I was with my family member who went through this process a few years ago. In fact, the treatment has been done and successfully done, but she still attend clinics from time to time, you know. But one thing I never saw, maybe now that she's going to this clinic now, maybe they talk to her about that. But when I was there, we never talked about anything about the cause. See, for me, I like to talk about cause of things. What is the root cause for this increase, for cancer itself? See, when people understand the process that causes cancer, maybe I know it's not everybody, maybe some people will start changing their, if it's lifestyle, then people will start changing the way they do things, you know, to ensure that their what's the word? That it doesn't happen to them. Okay. So what are the causes of cancer? You know?
Yeah. That's a great question, Akene, and actually a very complex, a very complex one in its simplicity, because the simple answer is nobody knows, right? The reality is, Akene, as we're both sitting here and having this wonderful conversation, is that we're all producing abnormal cells.
Yep.
And our bodies are routinely sort of clearing those.
Yeah.
Right? Now, what happens and what causes the switch from this abnormal abnormal cell that goes on to progress in certain people, nobody quite knows. I mean, there have been several theories around, and we do have a couple of demonstrated risk factors for sure, and we're going to probably maybe chat a little about those. But it's interesting that if we look at it in terms of risk factors, we do know, as far as data suggests, that anywhere between 30 to 40% of cancers can be avoided by avoiding some of these risk factors.
So please focus on that. And
yeah. Absolutely. So we do have what we call modifiable and non-modifiable risk factors.
Okay.
Now, non-modifiable is, for instance, the fact that you can't change the fact that you're, for instance, female or male. Right?
Okay.
If you're female, for instance, that automatically bumps up your risk of breast cancer significantly, right? And so we can't change the fact that we're growing older, right?
Yeah.
And because aging itself does, increase the chances of more abnormal cells escaping the control. So basically, I like to give you an analogy of the difference between a normal cell and a cancerous cell is that the normal cells are like us, right? So they're born, they're young, and they get into teenagehood, stress their parents a little, mature, become senior members of society and contribute significantly to the development of the body. And then, at about 65, they're retired and told, well done, good and faithful, cell, go forth and, and they're removed from the system. Now, the only difference between a normal cell and a cancerous cell is that a cancerous cell has escaped the normal control mechanisms of the body.
Yeah.
So the cell has now become what we call immortal. And so the fact that it becomes immortal now means that it keeps on dividing and dividing and dividing with no controls.
Yeah.
And so sometimes we always say, think of the cancer cell like a squatter. It now starts to take over areas that it's not supposed to. And so it sort of multiplies, and in time you start to feel a lump, right? Depending on where the cancer may initially present. And then being true squatters, they're always looking for other areas to occupy. And so they're always looking for, can I go? And so they figure out trajectories from respreading to the lungs or the liver or whatever. But it's not, interestingly enough, it's not the spread that's the problem. It's the fact that you're not able to have the normal control mechanisms.
Yeah.
So if, for instance, the liver is what's supposed to, remove all, detoxify or remove harmful elements from the body. and then you have something sitting there impeding its function, then what's happening is that those toxins are now accumulating in the body,
yes,
and are not exactly. So it's not the cancer per se; it's the fact that it affects the way your organs function that makes the difference.
Yeah.
And so, as we were saying, sort of circling back to the factors that we can modify. We can't change the fact about our age. We can't change the fact about the fact of growing older. But part of the risk factors and one of the factors that is speculated, you're asking what could probably be driving this increase, is around the concept of what we call our quote unquote westernization of our lifestyle.
Okay.
Now, if you think about what our grandmothers did, they would get up bright and early, maybe have wholesome meal, maybe some yams from the farm or some porridge, and then go to the fields the entire day, do a good day's work of digging or planting or whatever it was that we're doing, and then walk back home and have a great supper. If you look at kind of what we do, we wake up in the morning and we reach for the frosted flakes or whatever it is, and we quickly get an Uber or jump into your car and go sit in your office the entire day, push paper for whatever time it is, get an Uber or a car back, pass through KFC, get your fried food and things, and and promptly return. And so that has actually been postulated to be one of the reasons why we are seeing an emerging epidemic, not just of cancers, but even things like, obesity, including childhood obesity, which previously we wouldn't have thought about in sub-Saharan Africa.
Oh, yeah.
Just because we're more sedentary. So the two things that actually do make a difference. Again, some of the time, one of the myths around, sorry, I'm just going to talk about them non-modifiable so I can put them out of the way. But one of the myths we certainly hear around breast cancers is that, I don't have a family history, right?
Yeah.
So most people think that you need to have somebody in the family that's had cancer for you to have breast cancer.
Yeah.
And people think that one of the myths that we tend to hear around breast cancer is that, I don't have a family history, so I'm fine. Whereas we know, if we look at the data, that only 10% of breast cancers have a genetic component, meaning you have a member of the family that has a cancer. Most people will be familiar with Angelina Jolie and her family history and the fact that she decided to have a double mastectomy and have her ovaries out. But that is because she had a demonstrated family history where you look at her, what you call your first degree relatives. Her mother had a cancer, her aunts had all had cancer. And so she had a demonstrated gene, what they call the breast cancer, the BRCA gene, and that increases your risk of breast and ovarian cancers. But that's only in 10% of all cancers.
Yes.
The 90% of them, which is the majority of cancers, are what you call sporadic, meaning that
it just
arise and exactly, and nobody can actually explain why. And that I think is also an important concept, especially in the African context, where we always try to assign blame and meaning. Right? Somebody looked at me. That guy looked at me a little shifty. It must have been, or I put some little money in my bra, and that must have been the cause, or I bumped myself. So we're like, sometimes these things just happen. But in terms of, and again, it's also, we've talked about risks. So those are the non-modifiable stuff you can't change. You can't change who your family is. Luckily, you can choose your friends, but sometimes you can't change your family, right? But the things that you can change and do make consistent difference are diet and exercise.
Yes.
Right? And so I'll talk a little about that. Especially as far as diet's concerned, we say as long as you're eating healthy, that should be adequate. And what do we mean by sort of healthy? What we say is if you have an 8-inch plate, please note it's about 8 inch. Because sometimes we have this chat with patients when they come up with this like 20 or 12, 15-inch plate. We're like, no, that's not the size of the plate in question. But if you have roughly an 8-inch plate, we say half the plate needs to be at least vegetables, fruit or vegetables. Now, we always say, again, look at the preparation methods. I mean, if you're going to torture the vegetables on the stove for 2 hours and expect any nutritional value,
it's gone.
Yeah, then, that ship has sailed. And we say, if you're looking at things like cruciferous vegetables, cauliflower, the broccoli, it still needs to have the bite.
Yeah.
Right. And then if you're looking at things like leafy vegetables, the spinach, the kale, it still needs to be in that sort of bright green phase stage before it goes to a darker green.
Yeah.
And that's when you get the most nutritional value. Again, in terms of we say a quarter of the plate needs to be carbohydrates. And again, look at the carbohydrates that you're putting in. We generally have a broad distinction between sort of low foods that have a low glycemic index and a high glycemic index. I don't know if you've sort of heard the classification.
I haven't, no.
Okay, so glycemia is just Latin for glucose.
Yeah,
so it's just a fancy way of saying foods that have a high glycemic index have high sugars, basically. Now, the challenge behind, we always say as a rough guide, you want to be trying to incorporate foods that have a low glycemic index, meaning a low sugar. At least a lot more into your diet, more than foods that have a high glycemic index.
Yes.
Just as a rough guide, somebody once, one of my patients said, everything good in life seems to have a high glycemic index, but these are the more processed foods, the pizzas, the donuts, the pastries and stuff. But what happens with foods that give you a high sugar load is that the body's response to that is to give you high insulin. And insulin is the hormone that's involved with sugar production, which if you don't have, you get diabetes. But so you get high sugar, high insulin, and the net result of that is that you get your sugars going from really high, really low, dropping very rapidly. And the net effect of that is that's why you're like, dude, I just had 4 slices of pizza 2 hours ago. Why am I hungry? Right? And so the net result of those sugar fluctuations is that you now start looking around for something to
for
snack
food
on.
all
And that's
the time.
when you're more likely, and that's when you're more likely to hit on whatever's available, whether it's crisps, whether it's, candy, whether it's whatever. And so we say foods that have more complex sugars like the whole wheat or bran or whatever tend to give you a more consistent sugar level over the day. And so those at least, and that's why you notice sometimes when you take oatmeal or something in the morning when you're less hungry throughout the day and stuff. So investing in some of these healthier options. But again, with everything, it's a lifestyle. You're not just going to wake up and say, from this day forward, I mean, we're all going to have brown flour.
For me, I've modified my food a lot. Now I eat twice a day. I'm nearly 50, so I don't need so much food. I'm not as active as I used to be, so I have to reduce my food by half or even more than half, and I eat twice a day, and I eat a lot of fiber. I eat a lot of vegetables. I don't eat beef anymore. I haven't eaten beef for at least a year now, but I eat fish. I eat eggs. So I've changed a lot. I don't eat sugar at all. I don't add sugar, but I eat honey. I use honey rather than sugar. So I've made this kind of adjustments for myself. And I encourage my daughters to do the same, although they don't want to. They say no.
Exactly, and with all of these, as we said, it's a journey and it's a lifestyle, whatever that you're sort of gradually building in. And so what we encourage people to do is we say small, frequent changes and gradually try and incorporate some of these healthier options. It doesn't mean that for instance, that one of your daughters is having a birthday and you can't have a slice.
Oh no, of course,
and exactly. Life still has to go on. So as long as you're consistently making healthier choices, and as you said, you're not taking red meat anymore. And sometimes we underestimate. There's very good sources of, I would say, plant protein that we frequently underestimate. beans, peas, the legumes.
Yeah,
exactly. And then especially with the animal-based products, then we say you want to lean more towards white meat,
chicken,
like the fish and the chicken. It doesn't mean that you can't absolutely have red meat, but the recommendations are try and limit the portions that you're having and try and ensure that it's lean red meat.
Yeah.
Now, the other thing that does make a huge difference is exercise as well.
Oh, yeah.
Now, again, if you look at the World Health recommendations, they say, 30 minutes of cardio 3 times a week. Now, very few of us are actually achieving that.
Well, for me, I do at least 2 miles every day.
Oh, excellent. So you're one of the rare ones. And so what we say is
I'm trying to do it now when the sun is up, because by winter I have difficulty walking outside in the winter. So I'm just trying to if possible I could accumulate my walking for the year.
Your benefits now.
Yeah. Thank you for that.
What we encourage people is again just having small consistent changes.
Yes.
So you can tell yourself, because what happens and why people frequently fall off the wagon is, you wake up and you're like, okay, I need to get fit or I need to lose weight. And, you sort of say, that's me 30 minutes in the gym for the first 2 weeks. And your body starts to protest and say, I don't know what your plans are. So we say small, consistent changes. So even if you told yourself, I'm going to take, at least 30 minutes once a week and do that consistently for maybe 3 to 4 months.
Yeah.
And then try and build that up in time. To maybe twice a week, and then gradually maybe maintain that for another couple of months, and then gradually get to a level where it's become a way of life.
Yes.
The other thing we always encourage is find something you like to do. Some people like to go to the gym, bless them. Some people like to swim. Some people like to do Zumba. So it's more about finding something that's going to, interest and engage you and keep you active.
See, the more Africa becomes urbanized, the more we need to develop and adapt these changes, because the people in the villages don't suffer all those things,
Absolutely.
because they are active, they eat healthy, all these things.
Exactly.
And they are lean. They're not big and fat. They are lean.
And that's actually one of the challenges of urbanization. I don't know how true this is, but somebody was saying there's data to suggest that anywhere between 40 to 50% of women living in urban areas in Sub-Saharan Africa might actually be obese.
Yeah.
I don't know how true that is, but
I can tell you in Lagos in particular, you can see it everywhere. Okay.
Yeah.
You can see it everywhere very easily.
Yeah.
At least when I was there, Yeah.
And maybe just a note, Akene, on risk factors, because one of the things to sort of note about risk factors is that having a risk factor doesn't mean you're going to get a cancer.
Oh, yeah.
But also, interestingly, not having a risk factor doesn't mean you won't get it either.
Exactly.
Right?
Exactly.
Because sometimes people sometimes have a family history or whatever, and they're freaking out. They're like, what's going on? Am I at risk? And we're like, yes, you are at risk, but that might be maybe, depending on your family history, slightly higher, but it doesn't always translate into you will definitely get it.
Yeah.
And so it's important to have that consideration, because sometimes patients come and see us and they're like, I've been living healthy, I've been eating okay, I've been, going to the gym, I've been, honoring my temple and, eating judiciously. So why did I get my cancer?
Mm-hmm.
And so it's important just to realize, even with those, I mean, we're still all at risk, and that's why it's important to have regular screenings and things, especially for breast cancer.
The good thing is that in the UK, they do more regular screening. In fact, this shop close to my house, they have a truck with screening. So people come there, regularly, and our GPs send the ladies for screening, from time to time. So yeah, they're doing it. I hope Africa will come to an age where we do this more frequently, to help our ladies.
Absolutely. I think part of the challenge has been the cost of screening mammography. And I think part of the challenges have been just even the whole infrastructure to support screening and interpretation, because we've had, for instance, in Kenya, we've had all our counties, we have about 47 counties that have all been that have all had mammography machines, and now we're like, okay, we need people to actually man
do
the
it.
machines and interpret them. But that's only an additional, that's one layer. But the other layer is that, again, we also need to have a shift in terms of our approach to illness and health-seeking behavior.
Yes. Mm-hmm.
Because if we sort of talk to the average person on the street, there's you would find that there's a lack of awareness of the need for screening, and two, there's the mindset of, why am I going to look for trouble?
Yeah.
Right.
Yeah.
And so so I would rather not know. And we're saying, ironically, this is something you would rather know, and you would rather know early.
Yeah.
Right.
Yeah.
And so we sometimes give the analogy, especially for those who drive, is that, we treat our cars better than we treat ourselves.
Oh yeah.
Right. Because after every couple of hours, you take the car in for a service and get a check. Whereas for our bodies, if we use the analogy, we actually wait for the car to break down, and then we're like, take it to the hospital and figure out what's wrong.
And many times when our body is breaking down, we actually refuse to take it to the hospital because we are afraid of what the doctors will find, and we'd rather stay home longer than necessary.
Absolutely. And so we're saying that that's a major barrier that we do need to, that we are trying to address, but that definitely needs to be improved in terms of just getting into the culture of regular checks. And it's normal to actually have, an exam, even when you're feeling fine. And I think one of the ways that we've tried to approach this from a health systems perspective is looking at integrating screening with primary healthcare facilities, because that's ideally where the screening should take place.
Yes.
So any mother who's coming in for maybe antenatal screening or is coming for family planning services or immunization. The idea is to leverage those encounters and say, have you had a breast exam? Stuff and that kind of thing. Because again, many countries do not necessarily have the infrastructure to support widespread mammography screening.
Yeah.
But one of the approaches that we've been trying to have, especially in terms of downstaging, is early detection strategies like clinical breast exam. And so again, coming down to the healthcare workforce, if we're able to empower the workforce, this nurse who's sitting with this patient and offering family planning, just to give her the skills to talk about breast or cervical cancers, give her the skills to do a good clinical breast exam, and there's a potential of picking up lumps earlier and still sending appropriate referrals in a timely fashion. So that has been a key strategy from a policy level for many low and middle income countries in trying to sort of mitigate some of the challenges we're having with delayed diagnosis as well.
Yes. Very good. So you talked about the what's it called again? UICC earlier. Your role as a member of the board of directors, and you mentioned that you guys in Africa have a goal to develop a robust regional collaboration, for care and treatment of cancer patients in sub-Saharan Africa. So, as a region, so how is the process working in terms of the collaboration?
Yeah, so there's thanks, good question, Ekene, and I'm probably going to put on my other hat now because I'm the Vice President East Africa for the African Organization for Research and Training in Cancer.
Okay.
And so through aortic, as it's called, there's definitely been a number of in terms of knowledge sharing. Okay. Knowledge. So then, in terms of and I think we always say the silver lining behind the pandemic has been that we are more connected, as it were, and people are more receptive to virtual modules of learning and stuff. So there's quite a bit of, I would say, shared knowledge sharing. And this has translated sometimes into patient care.
Okay.
What's happened is, remember we talked about a multidisciplinary team approach towards care, and many centers maybe don't necessarily have all those cadres of professionals.
Very good. That's true.
And so now we're setting up virtual tumor boards where there's knowledge exchange. People discuss patients and management. So despite not having maybe an oncologist.
So this is a good impact of the pandemic. Very good.
This is as I said, one of the silver linings.
It will continue after. Oh, very good.
Absolutely. And again, now I'm going to talk about my other hat because as the chair for the Kenya Society for Hematology and Oncology, KESHO, what happens is we have a lot of regional shared knowledge. Ideas. So we, through aortic and KESHO, we pretty much end up covering most of Eastern and actually quite a bit of Western Southern Africa.
Okay.
And so speaking of screening and early detection, I'm going to throw a plug in for we're actually having a screening and early detection symposium on August the 19th, just looking at what are the innovations and strategies that we can employ to improve access and early detection of cancers for our patients. And that is actually a combined initiative by KESHO, aortic, and UICC to actually try and push the needle in terms of this particular symposium is actually through the efforts of aortic, KESHO, and the UICC. This is a collaborative effort to see if we can help to push the needle in terms of improving care for our patients and timely diagnoses.
Fantastic. Wow, Miriam, it's been exciting and very educational for me to talk to you today.
Thank you.
Right now, I'm going to ask you the last question. This is what I do for all my guests.
Okay.
So I ask people to look beyond the immediate horizon, to look 10, 20 years from today. So how do you see cancer treatment and overall healthcare in Africa in 20, 30 years from now?
Wow, that's an interesting question, Ekene. I think I'm actually optimistic. Hey, I'm really, really optimistic.
Good.
There's been, I would say, exponential growth. If we just look at the cancer space, for instance, over the last 10 years, we've seen almost double the number of countries in sub-Saharan Africa having a national cancer control program.
Very good.
Meaning we actually are acknowledging that this is a problem.
Yeah.
We need to be able to sort it out. And, we say the first step is actually acknowledging it. Now you can imagine if you're trying to sort out cancer and you don't even have a national cancer program.
Yeah.
Right. Now, those are the initial steps. Now it's getting the robustness behind how effective is this cancer control program? How are they, how are they behaving? But I think the reason I'm equally optimistic is one, the interest and awareness that that cancer is a problem and we are tackling it. But two, also the opportunities to collaborate. And I would say one of the things that we've experienced is almost, one would say, leapfrogging technologies. And I think one of the best things about, and I'm just bragging on my continent, is that we have the,
we need to brag sometimes. Yes.
Exactly. We have the brightest minds, innovations, and just looking at, we don't necessarily need to do we don't necessarily need to do everything exactly like it's done in Western countries. And I think there's been a growing critical mass of young oncologists, motivated, everyone keen, and not just oncologists, the whole spectrum, researchers, health workers, trying to look at how do we tackle and how do we get organic homegrown solutions for African problems, right? I mean, the days of us sort of waiting for, guidance or whatever to come from the mountain is long gone. We're sort of realizing, hey, this is where we are, and this is what we need to do. The solutions have to come from us, because we're the ones who know where the shoe pinches. And whereas we expect and appreciate and totally are appreciative of the collaborations that may ensue, we have to be the primary drivers if we are to impact care or make a difference in our communities.
Very good.
Stuff. So
very good.
The future is bright.
Oh yeah. See, I'm so happy I spoke to you today. I mean, we know cancer is a problem, and talking to you, our continent is taking it seriously. Okay.
Absolutely.
And so I'm also very optimistic about the future. Yeah, I am.
That's not to say that we have quite a bit of work ahead of us.
Oh yeah.
I think,
no, see, like you said, once you acknowledge anything, then you are preparing to deal with it, and that's all we need to do. See,
absolutely.
Yeah,
absolutely.
And thank you very much for being a guest of the Think Big for Africa podcast.
Yeah. Thanks so much, Akane. I'm hoping, I was grateful to be here, and it's been really nice exchanging ideas, and looking forward to thinking bigger.
Listen or watch more episodes of Think Big for Africa podcast with new guests every week. Subscribe to ensure that you are notified whenever new episodes are available.